Hello, everyone. Thank you for coming. Welcome to NAUTO's 39th Annual Conference. We will be starting in about 1 minute. Before we begin, we want to cover a few housekeeping items. On your attendees screen, you can enter comments or questions in the chat. We hope you will take advantage of the opportunity to engage with our speakers and other attendees. This session is being recorded. We recognize and thank the California Healthcare Foundation for being our Petabyte sponsor. Information about all conference sponsors is available in the sponsor area of the platform. Please take a few minutes to visit each sponsor's booth, where you can find information about them and find game tokens. Game tokens are keywords or phrases used in the token hunt game for a chance to win a prize in the daily drawings. Now, let me turn the stage over to Norm Thurston, NAUTO's Executive Director. Norm, the stage is yours.
Thank you, Erica. I'm pleased to welcome you to our breakout session today. This is something new we're trying this year called a POV session. POV stands for point of view, and we've asked our presenters today to just give their opinion or their point of view on whatever topic that they've chosen to speak on today. But they're all under the general category of data informing policy. Our moderator and organizer today is Craig Schneider from Health Management Associates. McKenna, if you want to go ahead and bring Craig to the stage. And we will turn it over to Craig to introduce our presenters and take it away from here.
Great. Thanks so much, Norm. So as you can see, I am not in the HMA offices today. I happen to be in my home office, which, as you might guess, is my daughter's room. But delighted to be with you all today, and I think you'll really get a lot out of this session. We have 3 wonderful topics with excellent presenters. We're going to hear about evaluating the impact of firearm-related injuries in Colorado. We're going to be hearing about towards integrated data, which you might say, ooh, what's that? And then we're going to hear about an organization called Fair Health and how Fair Health's data informs policy. Hope everyone enjoys this session, and I'm looking forward to the presentations and to a great discussion afterwards.
Hi, my name is Cari Frank, and I'm joined today by Clare Leather, my colleague today, who we're going to be talking to you guys about firearm injuries and how we are using the all-payer claims database to help legislators have conversations around smart gun control in Colorado. So just quickly about who we are. Civic is a nonprofit organization. We equip partners and communities in Colorado and across the nation with resources, services, and data, which we'll be talking about a lot today, to improve health and healthcare. We're a nonprofit, independent, and objective organization and very service-focused. Today, we'll be talking about what's in the all-payer claims database, some data analysis that we did using the database that we administer here on behalf of the state. It has over 1 billion claims from historic information from 2013 forward, and we have over 74% of the covered lives across the major commercial, Medicare, and Medicaid plans. So our firearm injury analysis came to be when a legislator approached us and wanted to understand beyond deaths, which a lot of death-related information exists about firearms here in the state, but no real data about beyond deaths and what is actually the frequency and impact of firearm injuries on healthcare costs and utilization, and what does that look like across the state. So using data from the APCD, we really wanted to provide some data-driven insights to inform legislative and public health discussions about firearm injuries in Colorado. So what we did was we looked at the different injury types, and those were based on CPT codes. We looked from 2016 to 2022 across all payers, and then also breakouts of Medicaid, commercial, and Medicare plans. We looked at statewide information, urban versus rural, and then county level information. We also broke the data apart between over 18 and under 18 to understand adults versus children, and then looked at sex, male versus female. Important to note that we do not collect death record information in our APCD. So some of these injuries may have resulted in death, but we didn't go to that level of understanding in this analysis. So injury type definitions, just to level set, unintentional is pretty straightforward. Accidental, discharge of a firearm. Assault is pretty straightforward. Undetermined is that there wasn't really a determined cause of why the firearm discharged. And then self-harm is pretty straightforward as well. And then we do have an other bucket, which is legal intervention of a firearm discharge. And that's when there might be a police altercation. Data definitions, we have total cost included in the analysis, which is the sum of the total allowed amount that the patient and healthcare plan paid. We have cost per event, so the total cost divided by the total volume of claims. We did look at total distinct number of claims, and that could be multiple claims for one person. You might have gone to the doctor several times as a result of the injury that you had. And then we did look at rate of incidence per 100,000 covered lives in the database. So some exclusions that we had were codes related to air gun, paint gun. We didn't want to include those. We also did not have any codes related to war operations. We also took away any claims that were reversed. And then following privacy standards, we always suppress any data that was less than 11 units. And now I'm going to pass it over to Claire to continue on with the presentation.
Hello, everyone. I'm going to jump in and take us to the finish line. We're going to talk about potential challenges to determining an injury category in medical coding. So incomplete or inaccurate information from patients or first responders can occur. There can be a lack of clear documentation in medical records. There can be difficulty in differentiating between injury types. And there can be coding errors and ambiguities. And there also can be delayed law enforcement reporting. Usually in these cases, there's an investigation that occurs by law enforcement, but sometimes the details aren't immediately clear to them about what happened. So even if law enforcement later determines the nature of the discharge, the information might not always make it back to the medical records for recoding. So that's important to know. Let's jump into impact and results. High level in 2022, there were 7,000 plus claims. This represents the highest volume of claims from the last 7 years. This looks like $8.4 million in healthcare spending across all payers in 2022. And from 2016 to 2022, we saw a 53% claim rate increase. In 2022, the injury breakdown looks like this. Unintentional claims made up a majority of the claims at 72%, followed by assault at 17%, undetermined intent at 7%, self-harm at 4%, and other for 0.5%. Looking at the data by age, we see that adults account for a majority of those injured, but we are seeing the greatest increase since 2016 to 2022 in those under 17 years of age. For this group, the largest increase was about 143% increase in the unintentional injury category, followed by the undetermined category at 111%, and we saw a 50% increase in injuries related to assault and self-harm. For adults, every category saw a percentage increase except for self-harm. Similar to youth and children, we saw that unintentional injury category increase the most for adults at 60% increase. Overall, the rate of firearm injuries is higher among men. This looks like 3 times higher than women among all injury categories, about 4 times more for unintentional injuries, 3 times more for assault injuries, and nearly 2.5 times more for self-harm injuries. Important to note, from 2016 to 2022, firearm injuries increased in nearly every category for both male and female. We are seeing a large jump in undetermined injuries among females at 233% increase. For men, we saw the largest increase in that unintentional undetermined category at 167 for unintentional and 29% for undetermined. Geographically, we are seeing our friends in rural communities experience higher rates of firearm injuries. In 2022, compared to urban counties, rural counties had 8 times higher rate for self-harm injuries, 5 times more for undetermined intent, and 2 times higher for assault and unintentional injuries. Both urban and rural communities are seeing an increase in injury rates for unintentional and undetermined injury categories. Additionally, the cost to treat an injury in rural communities is 25% higher than in urban communities. That looks like $1,500 per event in a rural community compared to $1,100 in an urban community. Finally, some cost findings. Medicaid injury rates were significantly higher than all other populations. While healthcare payments were the highest for commercial payers, the Medicaid injury rates were 12.5 times higher than commercial, 3 times higher than Medicare Advantage, and twice as high as Medicare fee-for-service. There's so much more to explore in this data set, so I encourage you all to access this public report. Feel free to use this URL link. It'll take you to the page where you can request this data. We just ask that you fill out a short Google form, and then we can send you the information. Here is our contact information, our social media handles, and then our website to join our email list. We'll jump into questions here. Thanks so much for your time.
Great. Actually, I think we'll take questions at the end just to make sure that we have time for all three presenters, but appreciate.
Hey, Craig, let's just go ahead and take the ones that we've got already, and then we can.
Yeah, okay, sorry. Okay, so pulling those up. The first question we got is, what is your approach to calculating total cost for Medicare Advantage and other capitated health plans?
We use total cost just with the allowed amount figures that we get. So we get the member liability piece and the plan paid. And so we combine those to get the total allowed amount. We don't have a lot of capitated plan issues that I'm aware of that we need to modify the way we do our methodology for that.
Great. Claire, do you have anything to add, or that's how you would answer the question?
Nope, Cari covered it.
Okay, great. Next question we got is, when using the term, quote, claims, for example, X% increase in claims, is that after collapsing the claims from a single visit into one claim, or are you looking at raw claims?
I think we're looking at just that particular CPT code. I don't think we were looking at the entire visit. So that was just the one claim line related to that CPT code. We weren't looking at a higher header level for this analysis. So there could be a lot of different things that happened during that one particular visit, but we were isolating it to that particular CPT code.
Great. And the final question we got is, did you use CPT codes in conjunction with diagnosis codes and external cause of injury fields to identify firearm injuries?
Claire, do you want to take that one?
Sure, yeah. We just used the CPT code. We did not use diagnosis codes in conjunction. The CPT codes that Cari talked about earlier were the only things that we looked at.
Great. Well, excellent questions, and let's keep it coming as we move on to our next presentation. Fellow colleagues from Civic, so some great research and analysis going on at that organization. So we'll turn it over to Valerie Garrison and Rachel Jardim.
And welcome. My name is Rachel Jardim, and I am an evaluation analyst at the Center for Improving Value in Healthcare, which we call Civic. Today, I'm going to be presenting alongside my colleague, Valerie Garrison, who's also an evaluation analyst, on integrated data, leveraging healthcare claims data and other data to conduct comprehensive research and evaluation. So we know you have already listened to a wonderful presentation by our colleagues today, but just a reminder, here is Civic's mission. We are the administrator of the Colorado All Payer Claims Database, the COAPCD. And Val and I are going to be talking to you today about research and evaluation at Civic, which is how we provide value to those that we serve. So one way that our department provides value is through research and evaluation services. Many of you here today are probably already familiar with the Colorado All-Pair Claims database. We know that it's a really robust database with remarkable quality and quantity. And one distinguishing feature of the Colorado All-Pair Claims database is that we have person-level identifiable information, which we leverage in research and evaluation in our department. So our department over the last couple of years has been innovating to provide these services to our partners. And one challenge that we've run up against is that the COAPCD does not provide comprehensive data on everything. So we know claims data are limited, and there are some metrics that we don't receive. Namely, we have limited information on social determinants of health. We have some information on measures like race and ethnicity, and we also don't get information on individuals who are uninsured. So today we're going to talk to you about how we have been supplementing the COAPCD with other data sources to provide more richness to our research and evaluation, bringing in other data to help kind of complete the picture for our partners. Some of the data sources Val is going to talk to you about that we've been leveraging in more recent projects are up on the screen. You all are likely familiar with several of these. The American Community Survey has really rich demographic data and is collected on an annual basis. We also have been working in partnership with health information exchanges to improve that transfer of data and that data sharing. More recently, we've begun leveraging mapping tools like ArcGIS in our evaluations. We also have begun integrating a wonderful data source called the Johns Hopkins Aggregated Clinical Grouping System, which provides person-level aggregated information. It analyzes previous healthcare utilization and assigns risk scores to individuals in the COAPCD and provides really wonderful summary metrics that we have been using. And lastly, Val's going to talk to you about some partner program data that we've also been bringing in. So I will pass it on to Val to talk about some of our projects.
Thank you, Rachel. The first project I want to talk about is an evaluation of how having access to a set of staple nutritional foods at no cost can impact members' quality of life and health outcomes. So some of the challenges that we've run into and had to work through with this partner are fair and equitable participant selection. They will be gathering up to 300 applicants, but the program is only able to cover up to 100 individuals. And so we are providing them with a community demographic profile based on American Community Survey data to ensure that their random selection of participants is representative of the service areas. Additionally, there are many different ways to define quality of life. So we worked with the partner to figure out which are the highest priority for this project, and then figure out, because there's no single data source with enough information for answering each of these questions comprehensively, figuring out with the partner how to collect all of that information. So our solution to that was we're performing a longitudinal mixed methods approach, combining American Community Survey data, member survey data, shopping cart information from the participating stores, as well as the Colorado All-Pair Claims database. And so you'll see we're really incorporating many different data sources, and we'll be using the ACG for cohort development using risk scores, as well as some of the outcome measures such as medication adherence. The partner program data that we will be receiving is going to be member self-report data, which is how we're getting the quality of life measures, as well as we will be receiving store shopping data through an API connection to the REDCap database. And lastly, we do have mapping selected. Our partner will be using mapping to based on member address and member movement throughout the study to make decisions about program expansion or improvement. The next project that I want to talk about is an evaluation of the impact on how investing in primary care infrastructure can affect primary care access and utilization, particularly in underserved communities. So this project has a really strong health equity focus. And one of our major data challenges, opposite from the last project, is that we will have too much data. We're looking at the entire state of Colorado over 10 years. And so we need to do representative sampling of the cohorts, or each grantee population, to develop evaluation cohorts. And so we'll be using ACS data for that. And also, to perform this analysis, we had to first determine what access actually means in the context of this project. So which access measures are most meaningful to our funder. And lastly, there are numerous factors that can influence primary care utilization in a community at the individual level, community level, and state level. And trying to account for all of those, we ended up with too many covariates in our model, and we had to simplify without losing context. So our solutions are to apply the Social Vulnerability Index from the American Community Survey, as well as using ACG acuity measures to indicate equity and utilization bands, which allows us to remove 3 to 5 variables from our model. We also plan to use ArcGIS to apply the integrated driving distance and driving time tool, which will allow us to calculate geographic access using pre to post differences in the average commute time for individuals traveling to healthcare. And so first, we can estimate the investment effect on distance from care. And then if shown to be significant, we can also include that in our regression, looking at the impact of that geographic access on primary care utilization rates. And again, we'll be using the Johns Hopkins ACG system to develop comparison cohorts and determine those acuity measures. So those are just 2 very brief examples of ways we're integrating this data. And we wanted to share with you the key takeaways that we have. Number 1 being that, yes, data integration is difficult, but it is well worth the effort. We are able to conduct much more comprehensive evaluations that lead to actionable insights for our partners. And the implementation of these multiple data sources allows us to provide accurate and reliable results that our partners can rely on. It also supports alignment with real-world experiences and needs. So really understanding different angles with context of data and being able to build that broader picture. And lastly, we really want to emphasize the importance of strong partnerships for the success of these data integration efforts. Not only have we relied on the subject matter expertise of our partners, both in identifying the data sources as well as interpreting our findings based on what different data sources reveal. But this work also requires effort from our partners for data collection and transfer. This is not something we can do on our own. It requires data use agreements and, in many cases, quite a bit of work for our partners. And lastly, it's really critical to build those strong partnerships for long-term data integration. So Rachel mentioned at the beginning that we're also looking into health information exchange partnerships to figure out how we can leverage these data sources, and to navigate the complexities and the logistical challenges of that is really based in partner development, partner agreements, and long-term collaboration. So with that, we want to pause and allow time for questions, but you can always reach us at rpi@civic.org. Thank you.
Great, thanks. So we have one question in the chat function already. Are you able to link person-level ACS data with other data sources?
So the American Community Survey does not have person-level data. It's really focused on a community. So an example of how we associate that with the person level, and I'm not sure if this specifically gets to your question, but so the Colorado APCD has all member addresses geocoded to the census tract level. And so we may not have specific demographic information about that individual in terms of income, race and ethnicity, poverty level, etc. However, if we can pull in the American Communities Survey information for the census tract in which they reside, for example, using the CDC's social vulnerability index, we can say we don't know about this specific individual. However, we know their level of social vulnerability based on the census tract in which they reside. So we're not giving information about the explicit person, but when we're bringing in and understanding the data from an equity perspective, we can look at where individuals reside and the degree of vulnerability that they have, and control from that perspective to see how our partners are impacting at a health equity level.
Great, thanks. Anybody else wants to add a question? We'd be happy to address it. So I was wondering that, as you know, we all want to come up with a pristine research design, but then data is data. So I was wondering how the availability of data sources might have influenced your research design.
Yeah, Val, excuse me, Val, do you want to take that one? I know you.
Yeah, sure. In some cases, it just makes it possible to even do the research. I think, and also being able to bring in that extra information allows us to build more meaningful comparison groups, so we can kind of use these extra measures, particularly the ACG system. I do see there's a question if we can speak more on the use of that. We can use the ACG system data to view like healthcare acuity measures or risk scores or predicted health outcomes and build populations based on that. So I mentioned with the primary care investment project, we had to reduce our number of covariates. Well, instead of using age band, healthcare cost, and line of business, we were able to use the resource utilization band, which is a predictor of how much or what degree of resources an individual is likely to need based on their age, their insurance type, as well as their overall acuity or comorbidities. So being able to use these validated measures to take scores that we know are accurate and reliable and consistent across populations, that lets us have meaningful covariates that help us reduce the number of variables in our models, have more meaningful results, as well as compare against more comparable cohorts.
Great, thanks. Got a couple more questions. What is the potential to link with electronic health record data?
Yeah, so I can speak to that question a little bit. We had a wonderful project we worked on earlier this year with another health information exchange. And there were a whole bunch of privacy considerations. And that, in the end, we actually didn't end up transferring data, but we worked really closely with their team to figure out how we could leverage information we were both collecting concurrently to avoid transferring direct data, but still link populations. And we wound up using a combination of clinic location, billing and service provider, NPI, and zip codes to create a cohort in the all-payer claims database that matched a cohort of patients in the health information exchange we were working with. So I think there's a long ways to go in terms of facilitating those linkages, but we definitely got pretty innovative in how we could create mirroring cohorts in both of our data sets.
Great, thanks. And then I think our final question, we'll move on to our next presentation, is did you use the OD cost matrix function in ArcGIS to calculate distances in the primary care infrastructure analysis?
So full disclosure, we actually haven't reached that stage of that specific project yet. What we intend to use is the ArcGIS, both business analyst and networking analyst licenses have a driving time and distance tool, which uses current street level maps to estimate the actual driving distance in time rather than a centroid point-to-point measure, which is the typical distance measurement. So we will be using that, looking at the input being the clinic address and the member address geocoded, and using that built-in algorithm.
Right. Well, maybe quickly we can address the last question. When you said the model was too complex, how many variables were included and why was it a problem given the sample size? Oh,
I can take it. Oh, perfect. Yeah.
Yeah, we can get back to that at the end if there's time.
All right. Great. Well, thanks so much. Appreciate that and the discussion. And we'll move on to our next presentation, Robin Gelburd from Fair Health.
Thank you for joining today's session. My name is Robin Gelburd, and I'm the president of Fair Health. I'm delighted to share with you the many ways in which our data help inform and serve as the backdrop for policymaking. Fair Health, as you may know, is a national, independent, not-for-profit organization. We house the largest collection of private insurance claims in the country. We now have over 48 billion claims from 2002 to the present. We receive over 3 billion new claims each year. We also are a CMS-designated national qualified entity and have been entrusted with the entire collection of Medicare fee-for-service claims, which accounts for another 48 billion plus claims for the period 2013 to the present. We feel privileged to be entrusted with these extremely valuable resources, and we feel a responsibility to ensure that the value inherent in these resources are made available to all key stakeholders in the healthcare system. In other words, we strive to make our data actionable. The billions of healthcare claims we house and secure would be of no value if the products and analytics and insights they yield become like a tree in the forest that nobody hears. Let me share a few examples of how we bring our data into the policymaking public square. In 2016, the opioid crisis was dominating news stories and public health concerns. One glaring gap in those stories involved the privately insured population. We investigated our own repository and saw that we had an abundance of information on that population and began to issue a series of white papers pertaining to the epidemic, each time through a different lens. We looked at demographic factors, geographic variation, and the economic impact of the crisis, among many other factors. Given the granularity and breadth of the data, these white papers echoed throughout government offices and policy institutions. For example, we were invited to the National Press Club to speak to journalists from across the country to help give depth and data to their stories on the epidemic, as well as invited to CMS to meet with officials grappling with the public health response to this crisis. Once we started releasing our opioid white papers, we saw tremendous interest from policymakers as well as from diverse media outlets. We felt privileged to be able to shed light on this very concerning public health crisis. Given the longitudinal nature and currency of our database, we often return to issues we have tracked previously to provide policymakers and others information about relevant trends associated with an area previously covered. The opioid crisis is one we have returned to. Most recently last month, as we released the latest edition of the Opioid Tracker, which provides a user-friendly state-by-state snapshot of current statistics associated with opioid use disorder and dependence diagnoses. Another area that Fair Health has shed light on includes the growing incidence of Lyme and other tick-borne diseases. In December 2019, Fair Health published a white paper on notable Lyme disease statistics in order to help fill gaps in knowledge and advance the work of other researchers. In the wake of that publication, the Subcommittee on Lyme and Other Tick-Borne Diseases, constituted under the 21st Century Cures Act, reached out to Fair Health to help inform its report to Congress under the Act. To assist this body, we presented data that built upon the analytics contained in our white paper. And as we often do, we returned to this topic recently to identify current trends in this area and release the detailed infographic in 2023, which was appreciated by the key stakeholders focused on this topic. Our Lyme statistics continue to surface in a wide variety of news outlets and serve as a backdrop for research and the design of treatment protocols. Our work associated with food allergies is another example of how fair health data inform policymaking. In August 2017, we released an infographic on various aspects of food allergies. That caught the attention of FARE, the Food Allergy and Research Education Network. They then commissioned a detailed white paper on food allergies that built upon the infographic. They had no editorial control over the study. They then used this independent data to populate state infographics for every state in the country in order to assist their conversations with governmental representatives about this issue. FARE, F-A-R-E, introduced Fair Health to the USDA and FDA as a result of this work. USDA recently authorized a study by Fair Health into pediatric food allergies and foodborne illnesses to help advance research in these clinical areas. With respect to COVID-19, we recognize that Fair Health data could play a unique role in illuminating the impact of the pandemic on the healthcare system writ large. Accordingly, as the incidence of COVID-19 began to swell during the first calendar quarter of 2020, we released our first study in March, and soon followed that initial study with a variety of other white papers looking at the pandemic from various angles. Fair Health, in effect, became like a data first responder during a very frightening chapter in our nation's history, one that required clear, unbiased, and comprehensive data to understand. In short order, we saw how our COVID-19 white papers were having an impact on policymakers and the public health environment. For example, in the May 2021 Federal Register, we saw our white paper reference, which demonstrated that those patients with intellectual disabilities and developmental disorders were having higher rates of mortality than other patient populations once infected. One of the confounding aspects of COVID has been getting a better understanding of what has been referred to as long COVID. In June 2021, we released our first study on this subject, which began to shed light on this perplexing condition. Our initial study in June was followed in short order with another study on long COVID, which was aided by the release of an official diagnostic code. Both the World Health Organization and the International Association for the Study of Pain invited Fair Health to present our findings to their members, given their hunger for trusted and independent data on this subject. As storms proliferate and other concrete signs of climate change emerge, there has been greater attention on how climate change may be impacting health. Toward that end, Fair Health was invited to speak to the White House Office of Climate Change and Health Equity. We explained that there are many ways in which our data could expose potential linkages between climate change and health. In the wake of that discussion, we published our white paper on heat-related illnesses, which documented certain trends during the period 2016 to 2021. Many policymakers have been focused on various issues associated with maternal health and childbirth. In January 2021, we released an infographic detailing certain data points bearing on maternal health against the backdrop of the pandemic. We also have looked at the varying costs associated with both vaginal deliveries and C-sections through a state-by-state interactive heat map. And most recently, we released a study on varying aspects of maternal health and giving birth in September 2024, which garnered wide attention from the press and policymakers alike. Given the unmatched collection of private healthcare claims housed in our repository, we are often the subject of a sole source procurement notice issued by governmental agencies to advance their policymaking and their respective studies. Here is one such notice issued by the CDC in April 2019 in connection with a pilot project they were undertaking. Two other examples of how Fair Health data have been the subject of sole source procurement notices involve the Bureau of Labor Statistics and the United States Department of Labor. Fair Health has been recognized as having the most comprehensive collection of telehealth data. We synthesize and make current telehealth data available through our widely relied upon monthly telehealth regional tracker and related white papers. Here you can see multiple references to our tracker in an ASPE issue brief, GAO report to congressional committees, and in a publication issued by the Federal Communications Commission. Here you can see how our telehealth data go beyond governmental and policymaking halls and also get incorporated broadly into diverse publications. Here's another example of how our data get utilized in policymaking settings. We released a detailed study on ground ambulance services in the United States. As you may know, the Federal No Surprises Act addressed air ambulance services, but with respect to ground ambulance services, the law provided for the creation of a committee that could advise Congress on a possible path forward with respect to surprise ground ambulance claims. Having seen our study, the Ground Ambulance and Patient Billing Advisory Committee reached out for additional data on this topic to help inform their legislative mandate. Fair Health has an enormous collection of de-identified data bearing on the mental health of both children and adults alike. This data became particularly valuable to public health officials and policymakers as we emerged from the pandemic. There was and continues to be a keen interest in mental health incidents following such a traumatic chapter. Our studies have found their way to school boards and other official bodies to help understand the issues presented and shape constructive paths forward. It's been a pleasure sharing these examples of how Fair Health data find their way into policymaking corners. I look forward to your questions.
Great, thanks. We have one question in the chat. Do you do any analyses at the county or census tract level?
Yes, we do. So our normal default is to what we call GeoZips. We have 493, which tend to track with the first 3 digits of the zip code, but we also can be rather nimble in organizing it by state, by county, by medical service area, rural, urban configurations as well. Depending on what the questions are being asked, we can help answer them through various geographic lenses.
Great. And while we're waiting for others to weigh in with their questions, I was intrigued by the comment in your presentation about being a, quote, data first responder. And I'm sure lots of people in the audience are thinking about this. You know, how do you balance the urgency of responding to timely requests with the need for accuracy? Particularly, we're talking about claims data, which we often experience lags in data claims runout periods. So just interested in hearing how you balance those two issues.
Sure. So given the billions of claims we ingest annually and the currency of the data monthly, we get our data feeds monthly. We have very sophisticated auditing and data validation tools that when ingesting the data goes through one auditing process as well. And then given whatever we do in terms of what we release, not only goes through an internal QA process, but we have an academic advisory board as well that's external, that's independent, that we send our data reports to and white papers just to make sure that the data findings are being represented clearly, accurately. And in terms of the runout, given how large the data set is, that does not necessarily disturb ultimately what those findings are. And if we do see any changes in time, we will return to the subject and obviously add to what was previously released.
Great, thanks so much. I don't see any other questions in the chat at the moment, so maybe we can return to Alim's question. When you said, for the previous panel, when you said the model was too complex, how many variables were included? Why was it a problem given the large sample size?
Yeah, so let's go ahead and bring actually all of our presenters on stage, and we can take questions for anybody. We start with that one.
And I can take a shot at that question. Alim, thanks for that question. That's really wonderful. We had a partner who was very interested in a whole variety of social determinants of health, and they had a list of nearly 20 variables that they were interested in considering. And of course, when model building, our team was using a causal inference framework and wanted to ensure that we didn't have high levels of multicollinearity between too many of our variables. So in order to select the most parsimonious model, we did our best to include only those variables that were contributing to the direct effects we were interested in looking at. But I think that the ACG systems that we use do a really great job of also summarizing some of the otherwise proxy variables we might have used. I know Val mentioned those risk scores in the ACG Johns Hopkins system, and that's oftentimes what we are trying to get towards when we're considering including other variables like age. So that was really helpful in our case.
Thanks. And it looks to me like Brian Hutchinson's question could be for all of our panelists. In the methods for your studies, do you show the codes you use? For example, CPT or ICD-10 codes?
I could take that first. And yes, in all of our published studies, we have a methodology section. We state specifically what ICD codes we are looking at and what CPT codes are likewise incorporated into the study very specifically.
Yeah, I'll just say the same goes for our study. We have a methodology page, and we list all the CPT codes that are included and the definition.
Same for us. We include it as an appendix. And I'll also note that we work with our partners to bring in subject matter experts to also review the code sets that we've selected to make sure that they're appropriate for the application.
Great. We have another question for Robin. What advantages come with being designated as a qualified entity?
Well, thank you for that question. So as a qualified entity, as I mentioned, we have all of Medicare fee-for-service parts A, B, and D. And what that allows us to do is issue public reports where we can juxtapose our commercial claims collection, which also includes Medicare Advantage, with Medicare fee-for-service, and really help inform the public and key stakeholders about variation in treatment protocols and utilization, et cetera. So it gives a very good window into a fuller view of the healthcare system at large.
Great. Do we have any other questions from any of the audience participants? We have a thank you. Do any of the panelists have questions for each other? I know you, the civic people, you can just, go to the water cooler and ask each other about your studies, but.
I suppose I have a question on the firearm study, which was really quite interesting. Were you surprised by the disproportionate number of unintentional injuries? Is that what you went into the study assuming would be the case? Because that was really quite, startling to me. And it'll be interesting to see if there are any resultants, any public health education campaigns in terms of how to handle firearms, different requirements about really storage and other, aspects of that would maybe reduce that high volume.
Well, we had done this analysis before, so I think we knew that there was likely to continue to be a high number of unintentional. The fact that it continued to go up in spades, so I think was surprising to us. And I think that it's telling that the legislator who came to us actually was hoping for that result, because he has challenges with his rural counterparts. They say, oh no, we know exactly how to use guns. We don't have problems with gun injuries or accidental things happening. And so I think that was helpful for him to engage his political counterparts in rural communities to say, actually, we do have some areas across the state that we can target those interventions and those community outreach and public health programs to really make sure that those communities know how to do proper gun safety and storage, and be able to focus those efforts and grant programs in those areas that need it the most.
Right. And the other thing that was striking about that finding is it seems very counter to the public perception of firearm injury risk.
Mm-hmm.
Yeah, I think people probably think assault and self-harm more so than unintentional. But the fact that there were a lot of children unintentionally getting harmed too is another really sad part of the story that data tells. Another opportunity. Thank you for your question, Robin.
Great. Any other comments or questions from any of the attendees or the panelists or Norm?
We have about 10 minutes left, so maybe what I'd like to do is to give each, there are 6 of you if I count Craig, just give each of you 1 minute to just truly POV, what's on your mind about health data, not even necessarily related to your presentation. Just give us a 1 minute brain dump about what's really cool, or what's the future, or what you think people should be thinking about. Well, maybe we'll start with Craig, because I'll put him on the spot and let the others have a minute to really think about it.
Yeah, well, the thing that strikes me is what are going to be the research priorities given the new political environment. So I'm assuming there'll be a pretty strong shift in what those priorities might be. And a lot of people are trying to figure out what the implications are for the science and research communities.
Okay, fantastic. Robin, I'm just going to go around the way you are on the screen. So Robin.
Sure. So we've been recently adding and embellishing our consumer website with a number of shared decision-making resources that bring the patient or caregiver into the conversation with the provider. I think no one should underestimate the appetite that patients and caregivers have for understanding their journey in the healthcare system. And I think it behooves all of us who are in this space to try to make that journey as clear and actionable and inviting as possible, so people are not intimidated, because it's a very intimidating world, the world of healthcare and healthcare insurance. So it's a challenge that we really try to undertake every day.
Okay, thank you. Rachel.
Oh, I think I would be thinking along the same lines as Craig. I think given the current political environment, I know our team currently is working with a whole variety of state partners that have shared the impacts of the Medicaid unwind since kind of the finishing up of COVID Medicaid eligibility. And I think that it's been a challenge for our team to consider how we might be able to glean insights on that population, and specifically understand what's happening to folks who are being kicked off of Medicaid. In the COPCD world, we are not really able to follow those folks once they are no longer eligible. So kind of to Val and I's presentation, thinking about what alternative data sources can we bring in to get more information on that population, and kind of help bring insights to the state so that we can better allocate resources in that way.
Yeah. So
top of mind.
Yeah. So have you tried to find any of them post Medicaid on some other type of insurance?
So we have, yeah, and maybe Cari and Clare can speak to a report we did on that. But I think that there's still a lot of looming questions about what happens for the people who are not able to find that are dropped off of Medicaid, and then if they don't appear again on a commercial insurer, are they being covered by ERISA plans, or more likely are they being cared for by the safety net clinics in the state, and they're becoming part of the larger uninsured population in Colorado. Yeah, Cari and Clare, I don't know if you have any insights on that.
We'll get around to them in just a second. In fact, let's just go to Clare. I'm just going to go around clockwise. Clare, go ahead.
So, Rachel, your particular report, I do not have a lot of insight. That is not my part of the shop, but I know we have been doing a lot of work for the state of Colorado to figure out what's happening with that population, and that's sort of ongoing work that continues to inform the policy of our state financing, healthcare financing organization. So that's really important reporting. So on the public reporting side, something that we've been doing and I think we've been pretty successful at is our APCD has been geocoded. And so we can take in that census data that Val and Rachel were talking about and put it next to all the measures and sort of integrating it into the public reports that we already produce. So that's been really exciting. So we've done something called the health equity analysis, where we take measures from our more community-focused population health public report, and we pull those in, things like ED utilization, well child visits, hospitalizations, and we pull that data right next to census data and look at those health equity factors that we're really curious about. Are people getting access to transportation? Do people have access to housing and food and sort of basic things, and kind of seeing the relationship between those healthcare measures and those health equity measures, and kind of putting them side by side and giving that as a resource to our community so they can really, really do neighborhood to neighborhood, sort of using that information to really target what the needs are of that specific community. So we've been doing that a little bit. We did a telehealth equity analysis, which is the same thing with telehealth services. We're including more race and ethnicity data in our public reporting. So that's something that our organization is really trying to be more thoughtful of and mindful of, and getting as much completed picture of that as possible in the APCD. So that's the work that I'm really excited about on the public health side, public reporting side, sorry.
Great, thank you. Cari.
Well, Claire kind of stole mine. I think health equity is always the big topic, right? And everybody wants health equity analyses, but they don't really know what they want when they say that. So I think we have, done a decent job at some first passes of what we can do with an APCD, marrying that with those factors that Claire was talking about. But that's going to be a continual work in progress over time. And I'm sure we'll learn more as we go. I think other big things on my mind, given the political landscape, are just making sure that our analyses are trying to ensure, and this is a hard one, that our analyses that we put out publicly aren't misused or misrepresented. We are going to be releasing our second gender affirming care access survey or analysis, not survey. Colorado is one of the first states to actually pay and make the commercial payers pay for gender affirming care services. So we're going to see an increase in the number of folks who are getting that access to that care, really essential care that in this political landscape. Some of that data is being turned around and misused for negative things against those communities. So that's kind of on my mind, is like, how do we make sure that we get the data out there, that it's transparent, but it's also used for the intended purpose to do good and to not negatively harm folks. So those are things that are on my mind. I'll pass it.
Yeah, we'll let Valerie bring it home. The greatest idea ever, and here it comes.
Oh, no. Never will make that claim. And I'm really glad that Claire and Cari mentioned the health equity report. Rachel and I desperately wanted to include it in our presentation, but could not get to 10 minutes. So thank you for sneaking that in there. I could talk for hours about what's on my mind about data, but right now, today is, along with that equity conversation, access to data. We've had a lot of conversations about the cost of doing data, the data challenges, the issues with doing data, the barriers, et cetera. I think that often comes up in conversations. But one of my favorite questions is, okay, but what can we do? If we don't have certain information, is there a proxy measure? If we can't, afford to do a full-scale 2-year evaluation project, what can we do? If we don't have certain information, can we get it collected somehow? And so for me, being able to bring data to partners who don't have access to it is kind of the number one thing on my mind. And one thing Rachel and I didn't mention is some of these other data sets are a way to reduce the cost of accessing data. So instead of calculating all these complex measures, maybe there's something that already exists that's quote unquote good enough. And so for me, it's thinking strategically about what exists out there and what really is the best platform, the best approach. Sometimes it's simply a spreadsheet in Excel. It doesn't have to be this big, beautiful Tableau dashboard, but really matching the needs of the people who need to access data so they can understand it and use it to do the decision-making that they need to do.
Great. Thank you. Thank you, everyone. Thank you, Craig, for organizing and moderating. And we'll see you all in about 10 minutes over at our closing plenary for the day, Filling Population Health Gap. So thank you all. We'll talk to you all later.
Thanks very much. Bye.